So today we have Dr. Ashna, and the topic that we are covering will be thyroid problems. Just to scope today's discussion, we will not be covering thyroid emergencies. So it will be just a non-emergency kind of issues that we face, and we'll be focusing more on some of the practical issues that are encountered, especially in the general medicine kind of context. So I think if you have, what will also be helpful is that if you have questions along the way, you can post them in the chat. Then apart from these set of questions that we've sort of like put together to answer, then if you've got some time, we can try to answer them along the way too. Okay, so without further ado, we can begin.
Okay, hi everyone. Thanks, Jermaine, for introducing all of this. So today's topic basically is quite a broad a topic to cover because there's quite a lot of things in terms of thyroid disorders. So the things that I thought we'd just look at is sort of weird TFTs and what to do, especially when you do TFTs inpatient. Briefly about non-thyroidal illness, again, something quite common that we see. And then with the other pathologies like Graves and hypothyroidism, specifically looking at sort of initiation of ATDs, monitoring, and a remission as well. And then a little note about subclinical thyroid disease and its management. So what to do with weird TFTs? So first of all, I think it's obviously everyone knows this, that thyroid dysfunction generally can have very non-specific symptoms, and they can be very difficult to interpret accurately in an inpatient setting where patients are acutely unwell. And deranged TFTs are very common in hospital settings as well. So previous studies, for example, showed that about 15% of patients who are hospitalized have TSH levels that are either just a little bit lower than the reference range or higher than the reference range. And another study showed that 2 to 3% of patients who have very high or very low TSH levels, less than half of them will actually have some kind of underlying thyroid disorder. So the main point to take away is that use a clinical context whether sending thyroid function tests is appropriate. And if you don't think it's that urgent, then maybe it's something better to do in an outpatient setting when the patient is well. So that's basically what we were just saying. So discordant thyroid function tests, how do you approach them? So the first thing is to reevaluate your clinical history and thyroid status. Just a small note that you should appreciate that as patients get elderly, their TSH will naturally rise with age. And then always look on the system for any previous TFTs to trend. So that's something that if you refer endocrine, usually we will go back and look through to find out. So whether that's on CDMR, on CPSS, or NEHR as well, that you can go to the endocrine tab in CDMR and have a look at the TFT trend. So that's quite helpful to know whether this is a new problem or something that's known about before. And then just very briefly, excluding other confounders. So of course, if a patient is pregnant, then that can affect their TSH levels, and that can be low in the first trimester. Generally, I guess we don't see as many pregnant patients inpatient. Thyroxine therapy. So if they're on thyroxine, of course, that's going to interfere with your interpretation. And in terms of medications, I think the three things usually, at least before you sort of maybe call endocrine, the things that you might want to look for is any previous history of amiodarone use, lithium, because these things can interfere with can affect the TFT results, and then biotin. So biotin is a supplement that's often used in sort of hair and nail supplements that people buy over the counter, and it interferes with the assay that's used for the analysis. So therefore, it's important that if they're on biotin supplements, even in an outpatient setting, if you ask them and they're taking it, it's something you can ask them to maybe stop for between 2 to 7 days and then recheck the TFTs. And then again, we'll talk about this a little bit more, but non-thyroidal illness, could this be that in the clinical context of your inpatient setting? And then if it's still persistently discordant, or say you're seeing a patient in clinic and they're having persistently dodgy looking thyroid function tests, then maybe you want to consider referring endocrine, because it might be something a bit more rarer, such as thyroid hormone resistance, or something else like an assay interference that we will then usually do some further tests for. Okay. So this is just a summary slide. I won't go through all of it, but it's just something good to sort of either keep on your phones or You can look up the reference later. But basically, I thought this is quite nice because it goes through different patterns of TFTs and what the potential common potential diagnosis could be. So, so this is quite a useful slide, especially when we're thinking about discordant TFTs. So yeah, so something to sort of keep on your phone, and this is the reference at the bottom left. So what is non-thyroidal illness? So basically, this is a very common sort of just an example of a case that I saw a few weeks ago in terms of what the TFTs might look like. And so they're a little bit funny looking. So then you might want to, obviously want to evaluate this further. So, so generally, for example, in this case, so this was a 65-year-old lady admitted from clinic with some non-specific weight loss of a few kilos. So that's the reason why the thyroid function test was done, which is appropriate because, weight loss can be associated with, for example, Graves' disease, etc. But she was also bringing a UTI at the time. She had normal TFTs recently, about 6 months ago, that was done in the polyclinic setting, and she had no other symptoms of hyperthyroidism. So in this sort of clinical context, again, like having a potential UTI and then admitted with this sort of non-specific symptoms, we sent off a total T3, which is low. And this is sort of a classical picture you'll see with a non-thyroidal illness. So what is non-thyroidal illness? So it's basically an absence of an intrinsic abnormality in the axis from your hypothalamus, pituitary, and thyroid axis. And it's thought to be a sort of secondary adaptive change. The mechanisms are debatable regarding the precise mechanisms for NTI, but, and I don't, in this diagram is not to go through, but just to illustrate that basically there's changes at every single level in an acute inpatient setting where changes can happen. So whether that's up in the hypothalamus and pituitary, where the TSH can be low in states of starvation or cytokine release in infections, etc., or even at the tissue level and then intracellular level as well. So that's why it's sort of thought to be multifactorial, and there's so many reasons about why the TFTs can be deranged. Low T3 is the commonest, as we showed in the previous slide, even in mild non-thyroidal illness. And you can actually get, in severe illness, you can get abnormalities in your TSH and T4. So I won't go into too much of the pathology. I know we're trying to keep this sort of broad, but basically just a quick note regarding thyroid hormone release. So most of your T4 is made in the thyroid gland, and the biologically active T3 is actually done at the tissue level, where there's extrathyroidal T4 to T3 conversion. And this is done by these two enzymes up here on the left, the D1 and D2 deiodinase enzymes. This allows each tissue to sort of self-regulate how much T3 they want, basically. So what happens in an acute illness is that this enzyme generally is inhibited or reduced, which explains why the T3 levels generally tend to be low. So that's that, and this is just a quick sort of overview of what the patterns of TFTs look like during non-thyroidal illness. So what you see here, just to focus on the black line, which is the TSH, you can see it dips down initially, and then it might recover and tend to go up even a little bit higher than your normal range before going back to normal values. The orange is the T4 level, which tends to go up a little bit and then comes down. Again, what we saw in the previous case example. And then the T3 level, which we looked at, is the purple line right at the bottom, which tends to be low.
Sorry, Ashna, can I have a follow-up question? Yeah,
sure.
So thanks for sharing this slide and this graph. I was just wondering, because I think the instances that we are often faced would be, I think if it's like a clear-cut hyper or hypothyroidism, then most of the time we tend to either act on it or get endocrine on board. But there are instances where it's sort of in keeping with a subclinical, either hyper or hypothyroid picture. And in those instances, I guess it can still be in keeping with the NTI picture. So are you suggesting that in those instances, if there are no symptoms, then what we should be doing would be to repeat it at a subsequent setting?
Yes, so that's a good question, and I think that's absolutely right. So first of all, thinking about why was the TFTs done at that instance? Was there a reason? Were they tachycardic? Were they in AF, for example? Was there some clinical reason why the test was done? So generally, we do the Jerry bloods and the dementia workup. So if a patient's a bit unwell with coming in with a UTI, and then you're trying to screen for other things, then maybe it's something to consider whether the test will be therefore affected by the ongoing infection, which could be a non-thyroidal illness, and you end up having to repeat it later anyway. So first of all, choosing the context in which to do it, and then correlating it with your clinical history as well, and what you're seeing in front of you. Does it match or does it not match? So a good question is whether, is it non-thyroidal or not? So I think, again, if they're unwell, then it could well be that. And if your T3 level is low in the context of a high T4, like this picture here, and the TSH is a bit suppressed, then yes, this is in keeping. And then you would want to repeat them in about 6 to 8 weeks time when the patient is well. Of course, if there's other features to suggest there might be some underlying thyroid disease, like they have some thyroid eye signs, or they look a bit, they look like they might have Graves, or they have a strong family history, or they're, on the other hand, they're bradycardic and they're very, you're worried about hypothyroidism, then you'd have to interpret that accordingly. So, but by right, generally choosing the correct clinical context to do the test, and then if it's just borderline abnormal and normal TFTs previously, then it's worth maybe considering just repeating it outpatient. Does that answer your question?
Yeah, thank you very much.
Okay, sure, thank you. So that's basically that. This is just a trend to show you what the non-thyroidal trajectory looks like in most patients. And then this other question that you commonly might want to, because when you're ordering T3, because I just told you that if it's non-thyroidal, then you can order T3. So two things to note: you can send either free or total T3. They're both available to order on the system. On a practical scale, generally most people will order the total, but you can also order the free. It's just that the free, generally for free hormone levels, always the assays are a little bit less validated and a bit more difficult to sort of basically look at, and less robust. So that's one of the reasons why we tend to order the total instead. It tends to be a little bit more stable as well.
Okay.
The other thing to note as well is that if the T3 comes back as sort of normal, then it could not always. So if it's low, then it's certainly a non-thyroidal illness. A normal T3 level in the context of hypothyroidism may not be the right situation. So you may still want to consider referring endocrine if you're worried about the clinical status, and then the T3 level is actually just normal, and the TSH is low. So a low T3 level in the context of a slightly unwell patient is more likely non-thyroidal, and then you can just leave that to recheck in 6 to 8 weeks time.
Okay, so do you routinely send the T3 in suspected NTIs, or because some people would just repeat the thyroid function test at a later point without doing the T3? So are there specific instances where you feel it is of higher value to do the T3, and
Yes.
maybe in instances that it may not?
I think it really depends on how deranged the TFTs are that will decide whether you want to send it off or not. So if for example, your TSH is totally normal and your T4 is like 17, just above the reference range, I would normally just completely ignore that and leave it alone. In fact, I wouldn't maybe not even recheck that in 6 to 8 weeks time. But I would say that as a general rule, if they're both a little bit deranged, they're both slightly out of their reference ranges, then it's worth doing. In that context where the TSH is low and then your T3 is also low, then you can at least say this is likely non-thyroidal.
Okay, thank you.
Okay. So moving on, this is a case scenario again. 20-year-old lady coming in with palpitations, some weight loss, some heat intolerance, periods are a little bit irregular, has dry, gritty eyes as well. So when you see this kind of case, whether it's a clinic or whether it's a new admission on the ward, one of the things that you want to, the couple of things you want to definitely ask for, again, this is just very brief. I'm not going that in terms of time, we don't have time to go through all the details, but usually definitely want to check that they've got their periods. When was the last period? We'll rule out pregnancy. Thinking about, I'm sure that we're all kind of thinking about whether this is Graves or not. So you want to know if they smoke, because that also affects thyroid eye disease, etc. And there's some hint that she might have some thyroid eye disease with this dry, gritty eyes. and asthma, because again, it affects what treatment medications you might give her. So, so basically, she on examination for this a patient that we made up, the heart rate was 100 and regular. She had a fine tremor and some mild thyroid eye disease signs, and her T4 is elevated and her TSH is suppressed. So I think most people would agree that this looks like this patient might have Graves' disease. So say you see this patient on call, or they get admitted onto your ward, or you see them in clinic, then what are the sort of things that you want to do? So I won't go into the pathophysiology of Graves and everything else. We'll focus on management. But basically, Graves is the commonest cause for hypothyroidism, especially in younger patients, and it's much more prevalent in females than males. So a very brief points just to help you on a practical aspect is assessing clinically. So looking for symptoms. And I just wanted to make a small note about eye signs, because it's something that maybe people outside of the endocrine don't always know or refer to. There is actually a thyroid eye clinic at NUH on Friday, every once a month on Friday, that Dr. Ganga runs, and generally, even if they have subtle signs of thyroid eye disease, it's worth sending them over for a review, because then they will usually optimize them and they'll follow them up as well. So that's something that you should just sort of know about when you are seeing these patients in clinic as well. And of course, you want to look for Graves-specific features in this patient. She already has some features of goiter, some eye signs, etc. And then sending the TRAB. So TSH receptor antibody is something that you can send. So it's run, just so again, a practical note, it's run on Thursdays, and it's something that you can't add test. So say you see a patient on, I don't know, Wednesday overnight or something like that, and you're planning to do some bloods, you may as well send off the TRAB so that at least it can be processed on Thursday. Otherwise, you have to wait for a whole week before the result comes out. So it's quite specific and sensitive for Graves' disease, and therefore it's worthwhile sending. So yeah, that's just another small note about seeing these patients overnight as well. And then two other things, do you do an ultrasound scan? So generally in the guidance, it's not, you don't have to do an ultrasound scan for all your Graves' disease patients. Usually if they, of course, if they're TRAB negative and you're in that, they're thyrotoxic or hyperthyroid, you'd want to rule out toxic adenomas and multinodular goiters. Then you'd definitely do one. Or if there's palpable nodules, then you can consider doing it as well. And then you'd want to initiate medications. So medications is two things. Number one is your beta blockade, and number two is, of course, your ATDs, which I will talk about in the next slide. Just with beta blockades, as we know, most people will use propranolol, the standard dose of about 20 milligrams 3 times a day, but you can vary that depending on how symptomatic they are. So it's mostly for symptomatic relief, reducing that heart rate down to about 60 to 80 in an ideal setting. And again, keeping in mind whether they've got any contraindications to beta blockade, especially asthma is the commonest thing to ask about. And if there is active asthma or any concerns, then you can consider using an alternative, which is like diltiazem or verapamil.
For the medications, do you start them like immediately on call overnight, or normally we can afford to like wait to the next day for medication initiation?
Okay.
Let's say they're not in storm.
Yes, of course. Yeah. So that's exactly the point. So of course, if you storm, that will be, we'll talk about that, I think at the next session. But in terms of overnight, so number one, if they're tachycardic, if they're an AF, they would definitely benefit from beta blockade. You can go ahead as long as, of course, their blood pressure, everything can take it, and no contraindications. With carbimazole, it's plus minus. I personally think that they can be started the next day. There's no major, like one dose of carbimazole is not going to, be in a non-emergent setting. You don't have to start it overnight, especially if you are waiting for the full blood count and the liver function test and stuff like that to talk about. So I would say that overnight it's not urgent to start the carbimazole, as you can say KIB and then the primary team can start it in the morning. But the beta blockade is something you can definitely consider for symptomatic relief and for heart rate control.
Thank you.
Okay. So initiating ATDs. So basically you have to ensure that you do a full blood count. So again, for seeing them on call and they don't have any recent LFTs, it's worth sending. Usually they'll have a full blood count done. So we want to make sure that there's no, neutropenia, etc., and that the liver tests are normal before starting treatment. So when I talk about ATDs, I'm mainly talking about carbimazole. Of course, we can also use PTU, propylthyroid uracil, but we use that much less often and only in selected settings. Again, in the interest of time, I won't go through that in too much detail, but generally PTU is reserved for thyroid crisis. So if they're in thyroid storm, and also if they are in their first trimester of pregnancy, or if they have some reaction to carbimazole and they can't take it. So counseling patients, there's a couple of things. Number one is about their side effects, which we will talk about a little bit more. And there's a memo that you can get on the intranet, which you must provide to your patients. If there are any plans for pregnancy in the appropriate patient setting, definitely you must tell them that they should not get pregnant until their thyroid function tests have, until the euthyroid basically, and to inform you immediately if they were to get pregnant. And smoking. So smoking cessation is an important aspect in Graves' disease, because we know that smoking can worsen thyroid eye disease, and therefore it's important to tell them about that. And then the dosing of carbimazole is another common question. What do you start it on? So the dose can vary between 5 to 30 milligrams a day. By most of the time, if you're seeing a patient on the ward who's got a newly diagnosed Graves, we will start between a dose of 20 to 30. But it really depends on how deranged the thyroid function tests are that might decide your dose. So as a rough guide, generally, if it's sort of 1.5 times above the upper limit, you might start at a lower dose, maybe around 10 to 20. And then if it's significantly elevated, then usually about 20 to 30. And the key with that is to start at a higher dose usually, and then we'll monitor and taper down the dose as we go.
Do we always do a once a day dosing, or at higher doses will you do split dosing?
Generally, most of the time we do once a day.
Okay.
The average dose we generally would start patients on is between 20 to 30, which is, so each tablet is 5 milligrams. So I guess that's a good point to note as well, how many tablets that it's actually for the patient to take every morning. So they're really small tablets. So generally I've had no problems with patients taking it once a day. I find it's easier for adherence as well, just to remember to take their medications once a day. But if it's a high dose, you could technically split it, but most of the time we will just do once a day dosing.
Thank you.
So monitoring the thyroid function after initiation is usually 4 to 6 weekly, depending on how sort of thyrotoxic they are, and how adherent and how worried you are. You can generally not longer than 6 weeks is, generally you want to check between 4 to 6 weeks, especially initially. Each patient sort of responds differently. Their T4 level might come down quite significantly after 4 weeks itself. So then you'd want to taper that dose accordingly. So in terms of dose tapering as well, how do you taper that dose? Generally, you can sort of do 5 milligram reductions or 2.5 milligram reductions, depending on how rapid it has been. So if there's a very significant response with your 30 milligrams, then you might want to reduce. Like usually I would start patients, say 30 milligrams for 2 weeks, and then ask them to reduce it to 25 milligrams, and then come in for their blood test 4 weeks later, and then taper down accordingly. So that's usually give clear instructions about tapering down the dose. And then you need to monitor quite frequently, usually between sort of 2 to 3 monthly for the first 6 months. And then depending on that trend, you can stretch out that time for monitoring as well. Annual TFTs is at the stage where they're super, stable on a steady dose, then you can consider annual. But really, even though that's what it says in the guidelines, usually you sort of tend to see them a little bit more often, especially if you're seeing them in clinic. So what happens if they relapse? And that's why annual TFTs, even once they've sort of, been euthyroid, you want to definitely monitor them if there's a risk of relapse, which we'll talk about as well. And at that point, you may then want to, when I say relapse, at some point you might want to taper them off and take them off their medications. And if they relapse, then you either restart ATD, or you may want to explore other options, including radioactive iodine. So what do I actually tell patients about ATD initiation? So I usually tell them, well, we're starting you on this medication. It's going to help to reduce your thyroid hormone production, and the aim is to get you euthyroid. We will do gradual dose reduction over time with regular blood tests. The general period of treatment is about 12 to 18 months. And that's based on evidence to show that more than 18 months, there's not as much benefit. And before that time period, there's a higher chance of relapse as well. So that's why the average is about 12 to 18 months. And then we tell them some patients end up on lifelong ATDs as well if we can't take them off their medication. Then I tell them about side effects. So again, general side effects for any medications as outlined there, but specifically agranulocytosis, small risk of vasculitis, and hepatic dysfunction as well. So this is what I usually tell them. If they have fever and a sore throat at the same time, they should stop their medications and get a blood test done on the same day for their full blood count. And if you go to Clinical Matters, ABCs of Endocrinology, and just over there at the bottom right, there's a medical information sheet which you can print and pass to your patient as well. So it's really important that you ask them to discontinue their medications if they have fever and sore throat, because there's a small risk of agranulocytosis, generally sort of 0.1 to 0.5% of patients. So it's very rare, but it can happen, and it's life-threatening. So therefore, it's important to tell them very clearly about that. And then other things I tell them is, of course, as we talked about, propranolol for symptomatic relief. So you can either give them sort of a standby to take as and when they need it. And then pregnancy, family planning, and smoking, again, as we talked about before.
Can I ask a question? Just to switch in here.
Sure. Hi.
Hi. The duration of your ATD, do you count from the day they become euthyroid and the TRAP become negative, or do you start from day one of the treatment? Because sometimes I have one patient, I have to change course from carbimazole to PTU because she developed side effect to carbimazole. So I was just wondering how do you count your duration? Yeah.
So usually so there's two things. Number one is that the T4 will normalize first. The TSH always takes longer to normalize. It can take weeks, if not months, before the TSH starts to recover as well. So but generally, when the T4 has become come into your normal reference range, from that point is usually a year at least of treatment. So 12 months to 18 months from the time that the T4 normalizes is what we use, rather than when the T4 is 66 or something very high. And with regards to changing medications, as long as they're exposed to ATDs and it's been effective at bringing down their that T4 levels, then you can just sort of take that from the time of their T4 rather than the duration of the ATD itself, even if you had to switch.
I see. And what about the TRAP? Understand if the TRAP never normalizes, the risk of recurrence is very high.
Yeah.
But is that a consideration factor in terms of whether to take them off or how long to keep them on the ATD?
Yeah, so that's a good question again. I think it's on the next slide. Yes, so basically the TRAB in itself is a predictive factor of whether they're going to, they're likely to relapse in the future as well. So generally, if I'm taking them off medications, I would like that TRAB to be either very, very low titer or negative before we take them off. So again, there's no consensus on that, whether it has to be negative before you try to take them off the medication, but it's definitely a positive sign if that TRAB has normalized, then you're much more confident at taking them off their medication. And at some point you can always trial off with, close monitoring if that T4, if they've been euthyroid for a long time. And yeah, but if that TRAB is persistently high or positive, then the chances of them coming off the medication is much less likely.
Okay, thank you so much.
Welcome. So so that sort of takes us to this slide about remission. So remission is when you are sort of biochemically euthyroid for at least 1 year after you stop your medications. That's defined as remission. And the remission rate for ATDs is not fantastic. It's 50% after 12 to 18 months of therapy. And usually your recurrences will occur within the first few years after discontinuation. And as we kind of broached just now, factors that are predictive. So there's all these different scores and things, but generally if they have a smaller goiter, they're less thyrotoxic, they responded their TRAB normalized when they were on therapy, or it's only minimally elevated, are much more positive signs for remission than not. So it's just something to keep in mind. And on practical accounts, generally sort of younger female patients who are more commonly get Graves are more likely to sort of go into remission rather than your sort of older male patients as well, who may need lifelong ATD therapy. So the options of treatment, apart from ATDs, is of course definitive therapy with radioactive iodine or with thyroidectomy, depending on the clinical context. Just in interest of time, I will not talk too much about that, but because the commonest thing we do is start them on ATDs. So that's what we're just sort of focusing on today. Okay, so next case scenario is basically a 60. So again, this was a patient I saw not that long ago, a 60-year-old lady who had sort of low-grade intermittent fevers for 3 weeks with some painful mild neck swelling, sometimes radiating up to her ear as well, and she had a tender goiter on examination. So this was her TFTs that were done. And so you can see the T4 is elevated quite significantly. The TSH is almost completely suppressed, although it's 0.01 still. And her TRAB was negative. So usually we would send off a TRAB, and this one came back as negative. So, this sort of is in keeping with something I'm sure people are now thinking it is a thyroiditis. And again, usually this is a classic thing you see an elevated ESR level as well, quite high, and even the CRP can be high. They can have a bit of leukocytosis as well. So this is a classic picture of someone with subacute thyroiditis. So we're just to show you where we are on the sort of outline of things that we're going through. We're just talking about thyroiditis now. So thyroiditis is inflammation of the thyroid gland with release of preformed hormones into the circulation. It can be painful or painless. So painless thyroiditis can be caused by drugs, especially TKIs, amiodarone, or it can be postpartum thyroiditis as well, which can happen after delivery. And then what other small group of patients to sort of just be aware of is your oncology patients who are on these newer agents like nivolumab and pembrolizumab, etc., that can also cause this thyroiditis kind of picture. So usually oncology will then do their TFTs and then find this, and that needs monitoring as well. So subacute thyroiditis, just as we saw in that clinical case, which with this neck pain and fever, usually precipitated by a viral infection, usually has these typical symptoms of neck pain and fever. Sometimes the neck pain can sort of radiate from one side, it can sort of move to another, migrate to another region of the neck, and they might have some tender swelling as well. And sometimes it does radiate to the ear as well, the pain. So in terms of treatment, usually you can give them NSAIDs for pain relief and for sort of symptomatic relief. And if that doesn't work, then you can give them a course of prednisolone. And I usually monitor TFTs sort of 2 to 4 weekly, because they can go into, they can become hypothyroid for a while, and then they'll eventually hopefully become euthyroid at the end of it. So often they will just totally recover, but it can take a few weeks for their TFTs to normalize. So that's, and it's not as common that we see thyroiditis, of course. Usually the standard things you'd see is Graves, a multinodular goiter in older patients, and then atoxic adenomas as well. But thyroiditis is something to keep in mind of. So what other tests do you want to do if you're suspecting a thyroiditis? Like when do you do an ultrasound and radioiodine uptake scan, etc.? So generally uptake scans we use in sort of 2 main things. There are other indications for doing them as well, but the main ones that you might want to know about is sort of nodular or enlarged thyroid glands for evaluation of the function and activity of the gland, and then thyrotoxicosis. So in America, in the guidelines, they will use radioactive scans as their first line to diagnose Graves, but here we tend to use the TRAB definitely more because it's obviously much easier as well. So this is just a quick picture of what they look like. So often we use something called technetium pertectinate to be taken up. And then this is the scanner will see that this first picture is your typical Graves picture where the whole gland is active. And then in the second picture is the multinodular goiter where there's multiple nodules and they're all sort of different variations of uptake. The third one, C, is a thyroiditis where there's reduced uptake, as you'd expect in thyroiditis picture. And the fourth one is just this little nodule just above the sternal notch you can see there, which is an autonomous nodule. So generally in your uptake scans, if you do them, you will find that in your thyrotoxic patients who are painless, who are postpartum subacute thyroiditis, amiodarone use, etc., or if they're Hashimoto's, they'll have low uptake. And they'll have increased uptake in patients who have Graves, multinodular goiters, etc., or if they're recovering from their thyroiditis.
So in instances where the diagnosis of a subacute thyroiditis is quite clear, we don't normally
need to do
the scans though.
Yeah,
okay,
yeah,
sure.
Exactly. I usually would just probably monitor first and see if they're recovering or not.
Okay, got it, thanks.
And then again, this is that same lady that I showed you. This was her ultrasound scan that she had done because they were, the TRAP was negative. She looked a bit thyrotoxic. They did a scan and then, and she did have a goiter as well. So then you can see this increased vascularity, which is quite typical of a thyroiditis picture. Okay, so just moving on to hypothyroidism. So basically, there's a few things. Again, we're not going to go very much into the whole pathophysiology, etc. I'm pretty sure y'all must be very tired of hearing my voice now. So just some quick notes. Always assess that clinical status. Make sure that you're ruling out sort of crisis, which is really very rare, mixed edema coma. And then sending off the TPO antibody is very helpful. It's quite prevalent. About something like 90% of patients with hypothyroidism will have TPO positivity. And the reason I say check weight is because you can dose your thyroxine dose accordingly, and IHD history, and I'll talk about that in a moment about why that's important.
Can I check the significance of the TPO antibody? How does it guide management, and is there any prognostic implications?
So that's a good question. So basically, so TPO is sort of the hallmark of autoimmune disease. That it's a very important thyroid peroxidase. It is an important enzyme in the formation of T4 and T3 basically in that production. So if there is an antibody against it, oftentimes it's very commonly seen with your hypothyroid patients. But you can have patients who have hypothyroidism who have TPO negative antibody. So it just helps with sort of diagnosis. It's not technically necessary, but it's often just done. It is most useful in your subclinical thyroid population, which we'll talk about in next time, because it might help to predict whether they develop overt hypothyroidism in the future. So that's sort of the main thing to note about the TPO antibody. Yeah.
Got it, thanks.
But it can be positive even in Graves' disease. You might get a slightly elevated TPO titer. So it's not as specific as your TRAB. So how do you start thyroxine replacement in patients who are overtly hypothyroid? So a few things. So generally, if you're young patients without cardiac disease, you can start at 1.6 micrograms per kilo per day. In patients who are elderly, so when I say elderly, anyone sort of age 65 and above, you want to be more cautious at starting that. And the reason is that we talked about earlier, I mentioned that TSH tends to be higher with age. So it might be physiologically that they have just a higher TSH level. So you don't want to need to be so aggressive with reduction. And second of all, if they've got ischemic heart disease or any concerns about that, you want to be very slow at how you start your thyroxine. So kind of the opposite of Graves. Here you're going to sort of start low and go slow at increasing the doses. There's no major rush usually. So you sort of do at 12.5 or 25 microgram increments every sort of 4 to 6 weeks, especially in your ischemic heart disease patients as well. And you're just looking for the TSH to be sort of in the normal range. So that, as you can see, the TFT monitoring also can be done a little bit more later than you would for your Graves' disease patients, because basically it just takes time for the TSH also to fall. And it's really important, and this is a key thing, especially for MOs seeing patients on the ward and when you're admitting patients from ED about that thyroxine dosing, asking if they're taking it correctly. So usually the blue part over here is what I tell my patients, to take it early morning on an empty stomach with plain water and no food or drinks or any other medications for at least 45 minutes. I mean, 30 minutes is what we usually say, but I say 45 just to give them a bit of extra time. And generally you want to sort of keep the TSH levels in the normal range, generally between 0.4 to 2.5 for younger patients, and then a little bit higher in your elderly patients. So what happens if you see a patient who's had some total thyroidectomy long time ago, and then he's on thyroxine, and then these are his TFTs, right? How do you approach this? This is again something quite common you see on the wards where you have your TSH is quite high. So I think the key thing is, obviously, as with anything, most of the time, are they taking their medications? So you definitely want to find out about adherence and remembering that taking it correctly, especially if they're on any other medications that can affect their absorption of the thyroxine. So history taking is really key at asking them about this and checking their other medications and supplements. So some common reasons for high T4 requirements could be interference with their absorption. So whether they're especially on calcium and iron are the commonest two things. Usually we ask them to separate that out by at least 4 hours because they can really sort of bind to the thyroxine and affect its absorption. And then other conditions like estrogens or pills that can increase the TBG, the thyroid binding globulin, or increase the metabolism of your T4, such as phenytoin. Or if they have malabsorption, so something worth asking about. And then, as we spoke about, the main thing is this non-adherence to treatment, which is usually they're not taking their medication correctly, or they're not taking it at all. So that's what we usually will see. Mm-hmm.
So for patients on those medication like PPIs, calciums, iron supplements, do you tend to routinely shift these medications to like night dosing, or do you tend to swap their thyroxine replacement to night dosing? Because I mean, if it's 4 hours apart, right? Even if we told them to take it on an empty stomach, realistically, these medications, if they are morning dosing, they would still sort of be quite close proximity to the thyroxine replacement. So how do you normally handle that?
So generally, so most of the time, we sort of stick with thyroxine to be taken early morning, because that's the best bet that their stomachs will actually be empty and there's better chance of absorption. But there are, of course, patients who work different hours, etc., who have trouble taking it early morning and not eating. They don't have time to sort of wait half an hour. So then we'd ask them, but usually tell them to wait at least 3 hours after their last meal before they take that thyroxine. So if it needs to be bedtime, then usually you need to give them a longer sort of gap between their meal and their thyroxine intake. So usually most sort of PPIs and cholestyramine, all these drugs can affect the absorption, but generally we just say, okay, just take it at least 45 minutes later. But your calcium and iron sort of have higher rates of sort of chelation and affecting the absorption. So generally, at least calcium tablets, we usually will tell them to take it at lunchtime if they can instead. Yeah.
Okay, thank you.
And then just a very important caveat, again, not very common because thyroid cancer we don't see as much, but just be aware that if they have a history of thyroid cancer, they might have purposely low TSH targets, and they might be on chronic suppressive therapy. So therefore their TSH may be low on purpose. So if they're seeing an endocrine person, for example, at SGH or somewhere, and their T4 levels, TSH levels are always less than 0.01, it might be for a particular reason, like if they've got thyroid cancer. So again, just something that's very nice guideline on thyroid cancer management, and just tells you roughly what the targets are for TSH, is available again on the intranet. So it's a very nice, clear guideline on the different targets. Thyroid cancer usually should be managed by an endocrine person. So at some, unless it was many years ago and then no longer under follow-up, generally there'll be some person following them up. So I would just be wary of that when we're seeing patients who have a history of thyroid cancer. Okay, so just sort of heading to the last part of things. This is another sort of case scenario which you might see where the T4 is in the normal range, but the TSH is significantly high. Right, so this is do we treat this or do we not treat this? So this is basically a whole other topic in itself, subclinical thyroid disease. Okay, I think we shouldn't take there shouldn't be too much more now. But basically, what is this? What is subclinical thyroid disease? It's presence of disease without any obvious symptoms. And in subclinical hyperthyroidism, your TSH levels are low, so that's why it's hyperthyroid. But the T4 is undetectable. So the TSH is low in hyperthyroidism or undetectable, but the T4 and T3 are normal. And then the opposite for hypothyroidism, which is a little bit more prevalent and common as well. And just a small key point to note that your TSH levels change at a log scale with your T4 changes. So small T4 changes can actually cause big changes in your TSH concentrations. So yeah, that's just something to remember. And that's how we use the TSH to diagnose subclinical disease. So very briefly, causes of subclinical hyperthyroidism is, all these conditions can cause them. I won't go through them in the interest of time, but generally things that we've already sort of talked about as well. And then the best predictor of subclinical disease progressing to overt hyperthyroidism is your baseline TSH level, especially if your TSH level is very low. So sometimes your TSH level is just a little bit low, more than 0.1. They may actually normalize, in a few weeks or a few months' time. But if your TSH is quite low, then that increased risk of progressing to overt hyperthyroidism. So it's just something when you again see these patients, and it's again something Jermaine mentioned, how do we know whether this is non-thyroidal or do we just, or whether we're dealing with something real? It really depends on your clinical context, and then again your TSH level. If it's very suppressed, then anyway you're going to monitor them, so you'd want to definitely make sure they follow up, because if it progresses, then you'd need to investigate and treat. So because of the interest of time, I won't go into all the evidence, but there is an association of cardiac mortality, AF, heart failure, and fractures associated with subclinical hyperthyroidism. And the general guidelines will say that if the TSH is less than 0.1 and they're over 65, you should treat it Okay, and that's or if they have other risk factors like atrial fibrillation, osteoporosis, or any symptoms of hyperthyroidism like palpitations, tremors, etc., some sort of symptoms, then you'd also want to treat it. If the TSH is sort of 0.1 to 0.44, so sort of low but not completely suppressed, then you can consider treating again if they're more elderly, because we again talked about elderly patients just generally physiologically having higher TSH levels, or if they've got heart disease or hyperthyroidism. So that's the general sort of guidelines in terms of treating subclinical hyperthyroidism. And your goal is just to normalize the TSH. Coming to subclinical hypothyroidism, again, we've talked about a few of these things in terms of whether that's Hashimoto's or whether they've been on drugs like amiodarone, etc., or previous radiation therapy. All of these things can then render the thyroid gland hypothyroid, and therefore these are some common causes that you might see. And again, it's associated with an overt hypothyroidism. So they have a 2 to 5% annual risk. And again, coming back to Jamin's point about the use of the TPO antibody. So presence of TPO antibody increases that risk of progressing into hypothyroidism. So usually if you have subclinical hypothyroid patient in front of you and you do the TPO and it's positive, usually you'll say, well, you have a slightly increased risk anyway now, anyway of developing overt hypothyroidism, especially since your antibody levels are positive, even higher chance. So we would need to monitor them sort of every year at the very least, because they can develop, or if they develop symptoms, then you'd want to check again sooner. And it's also associated with some cardiovascular risk as well. It's associated with elevated lipid levels, insulin resistance, weight gain, elevate dysfunction as well. There were some studies looking at whether it affects cognitive impairment, especially in your older patients, but there's no conclusive data. So yeah, that's basically what we were going to talk about. So when do you treat it? So if there are some associations, as we just talked about, in terms of ischemic heart disease. So if the TSH is more than 10, you treat. And treatment is the 1.6 mics per kilo that we talked about. If the TSH is less than 10, but above the normal range, and they're younger patients with symptoms, you can consider trial of treatment, or if they're TPO positive, again, you can consider. So this one is more of a consideration. So you can sort of talk to your patients about starting a low dose and seeing how they do. Some patients actually just have some vague symptoms. And the thing is, it's so vague, but you can, so if you feel that they're symptomatic, you can offer them a trial of therapy and see whether that improves their symptoms. So again, the goals of treatment is to keep the TSH in the normal range. And in your elderly patients, you accept a slightly higher TSH level. So that's pretty much it. This is just a very quick summary slide on some of the things we talked about today. So one, non-thyroidal illness, very common. Be selective at what patients you're choosing to do your TFTs on in patients. T3 can be helpful if it's low. You generally send off the total than the free, and you should ensure that they have some follow-up to recheck their thyroid function test 6 to 8 weeks later. Graves' disease, you start your ATDs at higher doses and you taper down by 5 milligram or 2.5 milligram reductions, monitoring closely, especially at the beginning of the therapy, and counsel appropriately and provide them with the memo. Hypothyroidism, you start at 1.6 micrograms per kilo as a standard dose, but be careful in your elderly patients who may need lower doses, so you start low and go slow. And counsel appropriate on appropriate administration, and keep in mind if they've got thyroid cancer, then they may have a different target for TSH. Subclinical thyroid disease is still contentious in terms of who do you treat and who do you not treat. Generally for hyperthyroidism, subclinical hyperthyroidism, you would want to treat if they've got some risk factors of cardiac disease or fractures, and you might want to test patients who are high-risk groups and treat to normalize the TSH. And in subclinical hypothyroidism, again, some cardiac associations, TSH tends to rise with age, so you can accept a higher TSH level for your elderly patients. But 10, even your elderly patients, is a cutoff for starting thyroxine treatment. And that's all from me. Do y'all have any questions? I haven't had a chance to check.